Vertebral artery dissection with basilar artery occlusion is an exceedingly rare cause of ischemic stroke, especially in young healthy individuals. It occurs in less than 1 per 100,000 people annually, and despite early intervention, it carries a high risk of mortality and long-term morbidity. This case highlights the presentation and successful management of a young weightlifter with a posterior circulation ischemic stroke secondary to vertebral artery dissection and basilar artery thrombosis. Timely diagnosis and efficient multidisciplinary management of this patient were crucial for therapeutic success. The patient in this case was a 25-year-old male with no significant medical history who presented to the ED over 20 hours after experiencing sudden binocular diplopia, vertigo, nausea, and gait instability. The patient, an avid weightlifter of 6 years, began noticing persistent neck pain over the previous month after heavy weightlifting sessions. He sought out physical therapy, acupuncture, and microneedling for pain relief with minimal success. He denied use of anabolic steroids, tobacco, recreational drugs, and had no family history of vasculopathy or coagulopathy. On exam, the patient exhibited rotary nystagmus, dysarthria, mild ataxia, and an initial NIH stroke scale score of 2. CT angiography and subsequent MRI confirmed a left vertebral artery dissection at the V3 segment and a 1 cm basilar artery thrombus that can be clearly seen in Image A. Image A shows a CT angiogram of the brain, and the arrow points to the thrombus in the distal basilar artery extending into the P1 segments of both right and left posterior cerebral arteries. This occludes the right superior cerebellar artery and the perforating branches supplying the thalamus. This resulted in bilateral thalami, cerebellum, and occipital lobe infarcts. Given that the patient presented well beyond the 4.5-hour window for IV thrombolysis, emergent mechanical thrombectomy was performed by interventional radiology. If we turn our attention to Image B, we can see an arrow pointing to the Zoom 71 catheter that was advanced into the distal basilar artery and navigated into the P1 segment of the right posterior cerebral artery. Continuous section was applied here. Image C presents the successful retrieval of that thrombus and confirms the return of blood flow to the previously hyperperfused right and left posterior cerebral arteries. We can clearly see the specimen in Image D, which was collected from the tubing filter of the Zoom 71 catheter. As demonstrated by the imaging, the procedure achieved successful revascularization, leading to substantial neurological improvement. Post-procedure, the patient was managed in the ICU with antiplatelet therapy and nicardipine for blood pressure control to mitigate further risk from the dissection. After 3 days of monitoring, he was discharged in stable condition with plans for follow-up neurological assessment and imaging to confirm thrombus resolution. At follow-up, the patient demonstrated a return to baseline in neurological function, and imaging revealed sustained patency of the intra- and extracranial vasculature, suggesting effective treatment. At his 10-day follow-up appointment, the patient expressed having a linear bright spot in his left visual field, but otherwise he denied any focal weaknesses, facial droop, loss of sensation, difficulty speaking, or understanding. The plan at this point was to continue the aspirin 325 milligrams daily and obtain a new magnetic resonance angiography of the head and neck to monitor healing of the vertebral artery. A month later, the repeat MRI head and neck redemonstrated the left V3 narrowing with good distal flow. The bright spot in his left visual field had further decreased in size, and there were no new focal deficits. The plan at this point was to continue daily aspirin and repeat the MRI head and neck in 6 months, with plans to reduce the aspirin if all went well. This kind of recovery was truly remarkable to see. The basilar artery occlusion mortality rates are recorded to be as high as 90% without treatment and up to 50% even with early intervention. Up to half of survivors experience long-term cognitive, motor, and neurological deficits, with 15 to 20% developing locked-in syndrome. Clinicians should maintain a high index of suspicion for vertebral artery dissection in young patients with acute neurological symptoms and a history of recent physical strain, even in the absence of traditional risk factors such as vasculopathy, hypercoagulability, metabolic disease, and drug use. This case highlights the importance of early imaging, coordinated interdisciplinary care, and timely intervention in optimizing outcomes and preventing recurrence in these patients. Currently, there is limited literature on the effectiveness of mechanical thrombectomy in posterior circulation strokes, especially for patients who are ineligible for IV thrombolysis or who have features of simultaneous intracranial and extracranial arteriopathy. This case emphasizes the potential of mechanical thrombectomy as an effective treatment modality for posterior circulation ischemic strokes secondary to vertebrobasilar artery occlusion and provides valuable insights that can inform the future management of similar cases. Thank you.